We're here at the 21st CROI in Boston, Massachusetts with Joel Gallant from the Southwest Care Center, formerly of Johns Hopkins, so that people say, I thought he was with Johns Hopkins.
Yeah.
You were.
I was.
So,
and I still have an adjunct appointment there.
Right, I understand that, but you love where you're living now,
Yeah.
and that's great. I'm glad for you. We always use your wisdom to pick your brain on what you've either heard in the halls that were exciting, and of course what you've seen in the various abstracts and so forth. So tell us about what you've picked out as important.
Well, since I usually focus on antiretroviral therapy, I'll talk about that. There's, of course, plenty of other interesting things here, hepatitis C, prevention.
Yeah, it's become a broad conference.
Yeah, it's very broad. So sometimes you feel a little guilty for focusing down on a
20-ring circus.
But that is what this conference used to be mostly about.
Yeah.
So there were a couple very eagerly awaited studies. One was the NEAT study from Europe looking at nucleoside sparing regimens, and the other was ACTG 5257, or the Arden Study, which was a comparison of three current recommended regimens. We'll start with the latter. So that was a comparison of three standard of care regimens, Truvada plus boosted Reataz or atazanavir, Truvada plus boosted darunavir or Prozista, and then Truvada plus raltegravir or Icentris. And it was important, I think, because it was looking at for people who really couldn't take efavirenz or Sestiva, which has been a standard of care regimen for so long. And what was interesting was that in the virologically there wasn't much difference between the three regimens. But if you looked at toxicity outcomes and ultimately at the overall outcome, in fact the raltegravir or Icentris arm was superior to both, and the darunavir or Prozista arm was superior to the atazanavir or Reataz arm. And it's interesting because this is despite the fact that raltegravir is given twice a day, so it was a twice-a-day regimen turning out to be the winner compared to some once-a-day regimens. And of course, this isn't because it's more potent or stronger, it was because of more dropout in the other arms. And the main thing that influenced that was the dropout with atazanavir due to high bilirubin and jaundice. There's one little issue with the study that I want to know more about, and that is that it looks like people could switch from atazanavir to a comparator arm just for having a high bilirubin, even if they weren't actually jaundiced. So,
right.
How much does that really reflect what happens in the real world, where you wouldn't usually switch unless you were actually yellow?
That's what I was going to say. Would the doctor recommend, or would the patient feel like, doctor, I don't like this, or scared?
Well, it looks like it could have gone either way. The patient could want to switch, or the doctor could say, wow, that's a high bilirubin, you ought to switch, which, so, but still, I think it does, it certainly suggests that a raltegravir combination, despite being twice a day, is a good regimen. I think people will also extrapolate from that, whether fairly or unfairly. They'll say, what this is really telling us is that integrase inhibitors are a good way to start. Even though it was only looking at one integrase inhibitor. Suggests that I think that darunavir or Prozista, if you're going to use a PI, that's probably the one you would go to first.
Do you think twice a day as opposed to a single pill a day or a single dosage a day is really a challenge or a big consideration for people?
Well, I think, a lot of people have said once a day is so important, single tablet is so important.
Especially those that are making the pill.
Especially those that are making the pill. And of course, we've been worried that if drugs go generic, we'll have to break up these single tablet combinations. Yeah. This study kind of argues against that. It's saying, a twice a day regimen was superior to two once-a-day regimens.
I mean, it's like when you get up and when you go to bed, or supper or something. It seems like a pretty logical.
People clearly like being on once a day. They like being on one pill, but does it make a big difference? At least in a clinical trial setting. Now, granted, in clinical trial, subjects tend to be, maybe a little more adherent. That twice a day may not be as big of a deal for them as it would be for others. But this study kind of argues that twice a day can be just fine.
And there may be down the road a single dose per every month or 2 months or something like that of an injection.
Right.
But we may still have other drugs that people have to take in conjunction with that, unless we can manage to find that other combo.
Well, you know, the 744, which is the injectable integrase inhibitor, similar to dolutegravir, is being studied with a long-acting form of rilpivirine, which is a non-nuke. So there is a 2-drug combination that could be given by infrequent injections. So that's being looked at now, both for prevention and treatment. You know, I think it's not going to appeal to everybody. A lot of people would say, why would I do that when I can take 1 pill a day? But in certain settings, you know, prisons, methadone clinics, where you can have supervised therapy, and
for people that are just not, they can tell you they're not going to be able to commit to a regular dosing.
Yeah. And for prevention too, I think as PrEP, it could hold a lot of promise. So
we talked about that yesterday in the PrEP science to implementation. It seems like that would be it seems like there's a lot of pushback from municipalities and health departments and stuff like that. Because it's not just giving a pill; it's managing a person as though they're on treatment. Well, they are on treatment.
Well, it is and it isn't. I mean, I think unlike treatment, PrEP can be very simple. It can be done in an algorithmic approach. Do this, then do this, then do this. It doesn't take a lot of judgment or you know, dealing with toxicity issues. So I think that PrEP is a fairly simple thing, and I think the pushback about PrEP comes from all sorts of things that range from price to paternalism to being judgmental about sex and all sorts of things.
That's what I was going to say.
It's not that hard.
If you're not a doctor that's going to have a conversation, an honest conversation with your patient about sex, it seems superfluous to really.
Or if you believe that condoms are the be-all and end-all of prevention, and that is the gold standard against which all prevention is measured, never mind how many infections there are despite that we have condoms, then you're going to look at PrEP in a very different way than if you say this is another way of preventing HIV transmission.
Yeah, and maybe at the very least, discordant couples would be a good
yes and no. You know, I think
depending upon what their sexual activity is.
Yeah, but I mean, if you think about who needs PrEP, I mean, who's getting HIV, who's getting infected? It's not the negative partners of a positive partner. Because the positive partner is likely to have an undetectable viral load with very low risk of transmission. It's the people with multiple partners. If you look at in the East Coast of the United States, where I came from, it's young black MSM who are, you know, they're not in stable relationships. They're having sex with a variety of partners, and they're the ones where PrEP would be cost effective. If we were to give PrEP to the negative partners in discordant couples where the positive partner was on treatment, it would be highly cost ineffective, and possibly the risk might be even greater than the benefit, even though the risk is low. So that's not the group I think we should be targeting. It's an easy group to target, but it's not the right group. The right group is a hard group to target because the people
who get the best return for your investment. Yeah. Well, anything else at the CROI that you think might be?
Well, the NEAT study, I said I was going to talk about that. That was the study of a nuke-sparing option. It's really amazing. Here we are, 1986 was the first HIV drug. We're now 2014, and we're still using 2 nukes plus a third agent. And it's funny that we haven't gotten beyond that. And so this was like our best shot at finding, you know, what do you do when you can't use abacavir, you can't use tenofovir? And it was boosted darunavir, Prozista, plus raltegravir, Icentris. And it looked pretty good, but when you got to patients who were harder to treat, the ones with low CD4 counts, maybe the ones with higher viral loads, it was starting not to look quite as good, which is what we saw in the earlier ACTG study, where in high viral loads it just didn't work as well. So still a blemish, even though it's clearly a legitimate regimen, I think, for certain patients, but it's not a home run. And you know what's wrong with it? It's hard to know. Is it just adherence, that it was a once a day plus a twice a day pill? If we had used dolutegravir, would it have been better? If we'd thrown in 3-TC or FTC, would it have been better? You know, who knows? But it's clear that we still don't have we're still kind of married to this idea of 2 nukes plus a third agent for the foreseeable future. which is, it's okay. You know, the nukes are getting better, but it is funny that we're still doing.
I mean, we went up to the kitchen sink, and I know Dan Kurzis is always saying, well, you know, once you get more than 3 drugs, it's, you know, you're not really doing anything. You just have a lot of garbage in you.
Yeah.
But the thing is, we need to think in terms of bringing back to maybe 2 drugs. It'd be a nice thing.
Yeah, it would. And you know, there have been some study. For example, the study where they looked at Kaletra plus lamivudine looked very good, and it's a very inexpensive regimen. You know, so for cost reasons, there's a lot of people are looking at these things, but there's still nothing has unseated this idea of 2 nukes plus a 3rd drug, as much as we've tried to find alternatives.
And it may be because the adherence being not perfect.
Could be, but then again, you know, we just talked about 575, the ACTG study, where twice a day was actually better. So it's hard to say. On the one hand, the NEAT study didn't do quite as well because there was a twice a day component, but on the other hand, in the ACTG study, it didn't seem to matter.
Maybe with the 2 drugs, 2 doses a day, people are more inclined to remember that they are actually taking drugs. I don't know. It's just hard to figure out sometimes, and you can overthink it.
Yeah.
And I'm sure it's not one size fits all or one problem fits all. It's the people are people.
Right.
They're individual people.
But you know, when that study was proposed and initiated, everybody said that is the regimen. You know, you pick your best protease inhibitor. You got the integrase inhibitor. How could it go wrong? Of course, now we'll say, oh well, but it could have been once a day. You could have had dolutegravir. You could maybe you need to have some lamivudine or something like that in it. You know, who knows?
Is somebody
I don't know that somebody's going to look at that approach or not. But
I mean, do another study and
these are big studies that.
That's the thing. It's a lot of investment in it, and you really have to. People ask me a lot of times how I feel as a patient, you know, and how I would do this, and I said, don't even think that I'm your average patient, because I live a very structured life, and like you say, there are people that don't have a structured life, and that's very difficult for me to put my feet in their shoes, and it's just not possible. Yeah. So that they have groups that they bring in and talk to people, but I think we really have to get to know the patient and the subjects that are out there living their lives and run the trials as close to the reality as possible, because that's what's that's where the rubber meets the road.
Well, fortunately, I mean, treatment is clearly getting easier for people and easier to tolerate, easier to take, and so we're kind of now picking around the edges that, you know, compared to the kind of questions we used to address of you know, comparing 2 really toxic regimens and which one is better. Now we're saying,
and then there was the issue of when do we put people on treatment, mainly because we didn't want to give them toxic drugs that they would be on the rest of their lives too early.
Right.
And now we realize that the drugs are, I won't say innocuous, but they're not nearly as toxic, and clearly putting them on treatment, even for their own benefit, of forgetting the ability of them to be a treatment as prevention as being really a smart move.
And there's more and more data here at this conference suggesting that that's the right approach, that you prevent a lot of harm by treating right away.
Anything else?
Can't think of anything.
Okay. Well, listen, you do your good job and your favor to us every year by showing up here, doing a little bit of a talk on what's jumped out at us. And of course, this isn't everything. This is, like you said, a very small slice, a small slice of antiviral activity. But the CROI has huge, expanded, comprehensive issues. And of course, the ones that I like the most are the ones that how do people live healthier and feel better. Right. And of course, part of that is that we have drugs that are allowing us to do that in and of themselves. Right. Not to mention the fact that you now, because of that, you can even feel even better by doing exercise and nutrition and so forth.
Well, I mean, that's our job now as HIV docs. We're not spending much time talking about resistance or toxicity of drugs. We're talking about primary care. You know, how do you prevent heart disease? How do you prevent bone disease? How do you and some of those things are connected with HIV, but some of them are just part of living and part of doing primary care.
Maybe a little bit more impactful because you've been beat up a little more by the earlier drugs or whatever, and you've been taking the hits. But you know, if you live smartly, you're probably going to live a long and probably very healthy life if you work at it.
That's right.
and we'll make sure that they listen to that. Okay. All right. Thanks a lot.
Thanks,
All
Rick.
right, Joe.